This is episode 47 with Dr. Dan Rubin. Do you want to know all about lab testing for cancer? If the answer is yes, stick around to hear about it from Dr. Dan Rubin, whose practice of naturopathic oncology has been an integral part of the Phoenix metropolitan community for the past 20 years. After graduating from Southwest College of Naturopathic Medicine, SCNM, in 1997, Dr. Rubin returned to complete his residency. In 2004, he became the founding president of the Oncology Association of Naturopathic Physicians. The ONC-AMP represented a revolution in the field of naturopathic oncology, providing for the first time definition, validation, and standardization in the field of naturopathic oncology. Since then, Dr. Rubin has become an internationally recognized naturopathic oncologist. Dr. Rubin is co-founder, along with his wife, Deb Smolinski, MD, and medical director of Naturopathic Specialists, LLC in Scottsdale, Arizona, where he practices full-time as a naturopathic oncologist. At present, Naturopathic Specialist has served the clinical and logistical oncology needs of people from all 50 states as well as 19 countries. And this was an interview I've been looking forward to doing for a long time. As I was telling Dr. Rubin on the interview, in going to several different integrative cancer conferences myself, along with talking to people going through cancer just about every day, I never go that long without hearing his name. The man has helped a lot of people, so it was really neat to finally get him on the show to hear from the man himself. And we went quite deep into lab testing for cancer, as I mentioned a moment ago. What is the body trying to tell us through the fluids of the blood? How do we test to find out just how it was the tumor cell was able to leave its home, travel through the blood, and set up shop somewhere else? What can a circulating tumor cell tell us that conventional testing won't, especially when it comes to monitoring cancer in remission? And we spent quite a bit of time talking about some of the newer therapies that the institutional side of things is rolling out with immunotherapy and checkpoint inhibitors and such, and what Dr. Rubin thinks about them and how he works alongside of them. Before we get to the interview, I do want to remind you that you are watching or listening to the newly renamed Integrative Answers to Cancer, where we bring all sides of the discussion on how to reverse cancer to the same table to give you one place to tune into for the most well-rounded perspective possible. As it's still newly renamed, we're still working on a new intro and all that jazz. You'll probably have to bear with us through some formatting changes over the next several episodes. I would like for that to all happen at once, but we are literally a mom and pop shop here, so things don't always happen as fast as we'd like them to. And the main reason for the constraint on our bandwidth as of late is the last thing I'll mention before the interview, and that is what we've been referring to on social media as our top secret project. It's not so secret anymore. It is the Toxic Home Transformation. 35 of our favorite health experts all coming together to discuss everything you can do to make sure that your home is a place that promotes health and healing rather than sickness and disease. Chemicals, heavy metals, mold, EMFs, bad light, bad energies, bad frequencies. In general, we talk about all of it, why it's such an important factor to your health, and what you can do to manage it all in one place. This is an issue near and dear to our hearts, as environmental toxicity is such a big suspect for us in childhood cancer, which is of course the reason I'm here talking to you today. But if you are going through cancer, the last thing you want is your immune system to be weighed down by a whole bunch of toxins that you're getting from the place you live, not to mention those toxins adding fuel to the fire. And if you haven't taken a hard look like what we're doing with this event, I can almost guarantee you that you are. We hear a lot about the potential toxins in food, and rightly so, but think about how many times a day you eat versus how many times a day you breathe. Please don't miss this. It's free. It starts on June 25th and plays for 7 days straight. You can sign up to watch it at thetoxichometransformation.com. That's thetoxichometransformation.com. Or if you're on our site, thesternmethod.com, reading one of our articles or looking for a supplement recommendation, you won't be able to miss it there as well. With that, I really hope you enjoyed this interview with Dr. Dan Rubin. Dr. Rubin, how are you? Thanks for coming on the show.
Hey, I'm good. Sorry about that. Great. Thank you for having me. I really appreciate it.
Yeah, no, I'm glad to get you on. I've been pretty, getting more and more involved into the naturopathic oncology world, and went to the OnCamp conference last year. I think I was the the only guy there without an ND after my name tag. That wasn't a vendor or something like that. And I think we ran into each other at Best Answer for Cancer as well.
In April of 17.
Yes.
Yes. Yep, right.
Yeah.
Got it.
But yeah, it's, in dealing with people going through cancer, trying to deal with it through integrative means, it doesn't take a couple minutes until your name comes up. So you're very well known in the world and very well regarded. And I've been looking forward to getting to pick your brain.
Excellent. Let's talk.
Yeah. Yeah. All that being said, like I was just telling you, people will have already heard your official bio, but do you just want to give everyone any kind of additional flavor in terms of, what you do and what you're passionate about helping people with? That sort of thing?
I got my start in the world of immunotherapy back in the day. I mean, back in the late 90s, it's still true. I mean, your first and last defense against cancer is your immune system, however that's regarded. And so back in the day, it was a lot easier to produce these types of therapies that we were doing. But since that time, and, since we weren't submitting new drug applications and, weren't, pharma companies had to switch gears a little bit. And back in the early 2000s, really became this is about, I'd say, almost 20 years ago, really became interested in terrain. And about 17 years ago, really began to think that what I do as a naturopathic oncologist or an integrative physician, whatever you want to call it. I'm a naturopathic doctor. I'm board certified in naturopathic oncology. Never really done any other work besides oncology. But the idea is that I realize that I don't really kill cancer cells well with my treatments. And, especially when you see different laws and limitations within the states where naturopathic doctors are licensed in, some people can give IV therapy, some people have prescriptive privileges, some people don't. If you look at Canada has a pretty broad law right now. The idea was, if you look at the profession as a whole, we don't kill cancer well, but chemotherapy does. Radiation can kill or stop cancer cells. Surgery removes them. Certain biological agents can certainly halt if the genomics, add up appropriately to the medicine. But at the end of the day, that's about it. There's very significant limitations of what conventional medicine can do. That's where there's this whole other world for naturopathic doctors, integrative practitioners, coaches, whatever it may be that the patient needs. And that was my big realization. Compounded with the fact that I really appreciate lab testing, because if you're going to talk about the terrain, or you're going to talk about the milieu, the stroma back then was really a big deal. And and you got to be able to test, and you got to be able to have some kind of metric. Big metric guy, big believer in, measuring response, not just looking at a CT scan, but you got to be able to other things to measure, because CT scans, they're you don't get them that often, and they're very hard to distinguish sometimes, but you can see a lot in the terrain. And so that really matched up. The stroma back in the early 2000s, late 90s, stroma was sort of the big deal, because Harold Dorchak, back in, I think it was either 85 or 95, I can't remember, really posited that cancer acted like an unhealed wound. And that really helped catch. Because if you really think about the leading edge of a tumor, or a tumor growing within the stroma, within a tissue, and how it has this leading edge which erodes basement membranes and sort of its natural barriers, it really does act as an unhealed wound. If you look at the first stage of wound healing, it's about growth factors. It's about neoangiogenesis. It's about creating this healing sort of factory. And normal wound healing goes to phase 2. And goes to phase 3, which is sort of the resolution of the wound. Even if it's a simple paper cut, right? And then you get your fingerprint back, and voila. But cancer never really transgresses from phase 1 to phase 2. So it's this evil cycle of growth factors, more wound, growth factors, more wound. So that was really my interest, because I knew that NDs, that was a domain for us naturopathic doctors. And it wasn't a domain for the conventional colleagues, because it's not, personally, what I believe, something that they think about, consider, have medications for. The structure of how they practice medicine isn't about that. But that's really why integrative medicine is so important, because of the world within which the cancer cells or the tumor lives. And that's how my practice then developed from about 2000, I'd say, to 2003 up into present day. So about, 16 or so years ago, and what I've really been focusing on. And, every day that we're in clinic, we refine our methodologies of our metrics, our testing, and how we apply therapies to patients based on testing. It's not like we have to test every person. Some people don't have the insurance to pay for the testing, and some people can't afford out-of-pocket testing. But at the end of the day, it's a very important part of how I approach a patient is lab testing. So that's what you're not going to see necessarily in my bio. I mean, you'll see achievements and et cetera, but when we sit down, whether it be myself and my resident or our staff, when we sit down and we talk to a patient, and we're really trying to take a deep dive into what the body is trying to tell us. And how do you read that? You read that through the fluids of the blood. You read it through a physical exam. You read it through how people respond to treatment. But it's very important to have metrics outside of just, hey, how you doing today? How you feeling? So, and I really think that it's true that why I am an integrative practitioner is because for me, it's very difficult to understand how in the world of oncology, now that I'm almost 21 years into this practice, how you can separate the two.
Yeah.
And I think we're talking the same language. It's, I think, why you're doing what you're doing, and why that your family's had the success that you've had, and why we're doing the practice we do in Scottsdale, Arizona, and Flagstaff, Arizona. We do have a clinic up there too. So can't forget the mountains.
We love the mountains here. That's for sure. Right in the heart of them. Yeah, no. And to that point, it's to our conventional oncologist credit, he even made the point one time, because he knows we're big into this stuff. That he doesn't even believe that there's conventional medicine and alternative medicine. There's just medicine that's been proven to work. Obviously, maybe his standard of what is actually quote unquote proven might be a little higher, and or a little different, I should say. And just he kind of acknowledges that he hasn't had that's not his lane. He hasn't had the time to look into it. But yeah. I mean, exactly. At the end of the day, we just we're trying to overcome cancer, and we want to know what works, and that's what we want for something that works.
It's sort of the notion that, I forget who quoted it, but I'm going to re-quote it, and certainly not my original quote. It's almost like, to the whole world, you're one person, but to one person, you're the whole world. And when we talk about, like you just said, standards, things that have been proven to work, well, they have on some people, but your son isn't just some people to you, right? To one person, you're the whole world. So that's, I think, what makes a difference. And it depends on what, like you said, your standards are. And every day I have many patients that are N of 1s. Everybody's individual. Genomics are different. And I think it's highly cavalier to believe that we can know and assume that each person's going to respond the same way, and they're not. So we know that conventional medicine takes big, giant, calculated steps based on what? Based on big data that sometimes takes a long time to generate. But they're doing it based on statistics and evidence like that. I'm not trained that way. And I'm not saying that that's necessarily the right way to do it. That's just the way it's done. And so what are we going to do? So we know that chemotherapy kills cancer cells for the most part. I mean, it pretty much does. But what about all stuff? So I think that's why we're talking integrated medicine. So anyhow.
Yeah, no, and like I don't know, maybe the kind of mantra that I had early on, and that I still try to pass on to others, is that there are no studies on you. It's kind of exactly what
you're saying. There are no studies on you.
It's I don't care what percentage you give me or anything like that. There's no studies on people going to all the links and like buying the friggin' infrared saunas and doing all the flooding my kid with nutrition through a feeding tube, and just that doesn't exist. That study does not exist. So
that's a great point. There are no studies on you. So essentially they're saying there's all these studies we've done on other people who have a similar diagnosis, but are, generally the same genomically, but they're actually not. I love it. I think it's a great philosophy. Thanks.
Yeah. Before I forget, could you back up just a minute and define the word stroma? I don't think that's been codified on the show yet.
Stroma. The stroma is generally defined as the supporting structures of the body within which parenchymal cells live. So parenchymal cells, or parenchyma, but it's really called parenchymal, are the functional units of the body. So in the liver, you have cells that perform the general liver functions of what a liver is supposed to do. That's the parenchyma. But there's a bunch of other cells in the liver that support those cells, right? Sort of like, somebody who supports, what you do, your family supports you, and that's the stroma of, you doing your projects, et cetera. So you can't have one without the other. Those cells can't live independently inside a body without stroma or the supporting structures. So that includes those like fibroblasts that produce a lot of fibrin, sort of like the net that holds, the structures in. It includes some blood cells. It includes, just general metabolic cells too. So that would be stroma.
Very good. Very good. So when you talk about lab testing, are we talking about functional, functional type, what's going on with the body, what kind of deficiencies are we looking at, what's your, metabolic activities like, all that stuff? Are we talking about, kind of the liquid biopsy, actually, testing the tumor and getting all that, genomic information and all that type of stuff? Or are we talking about both?
All. We talk about, let's talk about this. You and I are both trail runners. We've established that. There's something that calls us about a trail. And so we leave our house and we maybe you can run right to the trail. I have to drive to a trail, but whatever it is, we have very similar terrain that you and I run on, right? And so we have gear that allows us to run on that terrain, and we've trained ourselves to be safe on that terrain. And we go out and we come back and then we go back home. So if you think about it, a cancer cell has very similar aspects in that it leaves the parent tumor and it goes onto a trail like a blood vessel, right? Or a lymphatic vessel. And it has the opportunity to either be equipped to go on that trail run, so to speak, or that metastatic run, right? And generally, say a neuroblastoma cell or a hepatocellular carcinoma cell or renal cell carcinoma or breast cancer, whatever it may be, cell isn't necessarily equipped to live in the blood. Blood cells are, right? I mean, that's not what really hepatocytes do. But they also have the opportunity to die, or they have the opportunity to circle back. But metastatic disease is based on the fact that they don't, that they take this trail and they go live somewhere else. And that's a behavior. That is there's some kind of epigenetic phenomenon there that, number one, allows that cancer cell to leave the parent site, 2, to survive on that trail, and 3, to not come back home and to set up shop. You and I could do the same. We could go live and, figure out if there's food, et cetera. You know what? On a desert trail, it probably wouldn't do very well if we just, set out from our home with our running clothes and a bottle of water. If we come home, we have certain behavior aspects that cause us to do that, certain desires. And so and I was thinking about this on my run today, because as you and I were talking about how is this similar and what is it about terrain? Because I was running on terrain. I wasn't on road. I was on natural terrain. And so really, got me introspecting about this. And there has to be, it's the whole seed and soil hypothesis. So the point is how do you test that? How do you test that a cancer cell leaves? Number one, leaves, and it's a very important part. How do you leave the site? How do you survive? And how do you live in a distant site? The soil. And so our testing is all about that. And it may require a microbiome analysis. I can't say that that's for everybody, but in some cases, that's true. And because the microbiome produces physiological phenomena or creates the ability for our body to respond in a certain way. So I'd say first and foremost, really, it's generalized blood testing, something that we've developed panels and profiles. And we don't have like a name profile. Every person, every time we write out what labs we want them to do. It's similar but different, but a total N of 1 clinic. Truly, I don't think I could have it any other way, because at the end of the day, that's how I would want to be treated. There is, like you said, there's no studies on you. So let's, that's part of the whole doctor-patient relationship, et cetera. So what we can generally get from like a commercial lab in somebody's area, and it's not, number one, just as important as figuring out what tests to do is the interpretation of them as a group. There's very few tests that we use as a standalone, maybe like a thyroid test or something, if you're just testing thyroid. But how does hemoglobin interact with interleukin 8? What are the significance there? Or how about interleukin 8 or VEGF? Do you run a VEGF plasma or VEGF serum? Do you want to, do you need to look at a VEGF mutation? Those types of things. Do you have an invasive tumor? Do you need to look at a matrix metalloproteinase or do an immune testing? So, so that's sort of like what is the stroma telling us? And then you have to think about, this is looking at the blood, which is whatever blood is passing the needle at the time you happen to be drawing. That's a very important concept, right? Mm-hmm. Because we're also talking about trying to test things in the blood that don't originate in the blood. Right? If you're talking about somebody having a tumor and you're trying to figure out the stromal activity, but you're only looking at the blood that's passing through somebody's arm or somebody's port, how far away is that from the tumor? How much actually, one of the important concepts for any practitioner to think about, or any person who's getting lab testing, is one, you have to interpret as a group. There's a story that these lab tests tell us. And the elegance in the story is about how you look at them as a whole, and that's how you understand physiology and oncophysiology, et cetera. So if you're just jumping in and just starting, you could make some mistakes or you might not see the whole picture. But the other thing to think about is, hey, what's happening now that I see this? What the heck is happening at the level of the tumor? How much actually leaked out of the tumor? And there's a whole story to be told there too. So that's very important. Then you asked about, and stop me because I'm probably going to do a whole soliloquy here, but just cut me off if I'm saying something funny or you need to ask a question. You asked about genomics. You asked about liquid biopsy.
Yeah.
It was just a recent publication, I think, came out earlier this week that demonstrated that there really isn't any good solid evidence that treatment based on liquid biopsy is any more effective than physician's choice. I saw that data. I was like, okay, that's still an overall thing that doesn't necessarily 100% pertain to the person sitting in front of me right now at 11:37 a.m., sorry, which is there's no studies on you. And because, and that's also too, is testing costs money. And so do you do a liquid biopsy? Do you, how do you sort of juggle between, do you do a nutritional test? So it really depends. Is somebody right at the, early diagnosis? What stage are they in?
I think you might have put something over your mic, Dr. Rubin.
Am I good now?
Yeah, you're good now.
Okay, I think I put my finger over. Sorry about that. So, the point is where is this patient? How would the testing apply? Were they did somebody have early stage disease and they had surgery, now the tumor's not there? And it's kind of too late to do certain stromal testings. But I can tell you one thing that I have found over the last 12 years, that there are certain people that have certain abnormalities. An abnormality in their blood that persists despite time and despite treatment and despite disease status, that I truly believe were a central cause of their disease but couldn't act alone. For instance, insulin-like growth factor 1. Been measuring that for about 15 years or so. And now it's it's starting to become popular. Certain IGF blockers, people are recognizing IGF-1, IGF-2, et cetera, and that whole cascade. But I have patients that I've been measuring for over a decade now, and they continue to have a high IGF-1. They don't have cancer back. And we've certainly normalized all the other labs. So, but the IGF-1 persists. So obviously that helps them heal, and it makes them usually more muscular and, more robust in terms of like athletic injury, et cetera. And I truly think that the IGF-1 became exploited in some of these patients, but they may have had a high C-reactive protein. They may have not been getting sleep, and they may have had stress, and they may have had a high interleukin 8. We normalize all these things, and that IGF-1 actually may act as a pro-health molecule instead of a pro-disease molecule. And so that's where experience and testing comes in. And if you don't test, you don't know, right? So anyhow, that's the point.
Yeah, that's this is this is all really good stuff. Do you before I forget, do you have you mentioned microbiome testing. Do you have a particular microbiome test of choice that you're using these days?
Yeah, there's a host of them out there. There's Viome, which is more of a subscription model, and really kind of a high tech company when it comes to microbiome. So top
I'm
notch.
really interested in them. Yeah.
Excellent, excellent. There's certainly the GI effects, which I think is from Genova. There's the Gut Zoomer from I can't remember the name of the lab, but that's a nice one. There is Ubiome, but at the end of the day, it's only a small amount of stuff. They're only looking at what we can look at, and so it's sort of like the whole genome thing too. It's like we can do even if you're not looking at the cancer cell and you're looking at the germline, you're looking at nutrigenomics, or you're looking at detox genomics or methylation genomics. It's like, okay, we can pick out a few things, but what happens when we do that? What are the epigenetics behind that? Is it even okay to treat something that you only know a little bit about? And the same thing about the microbiome, but got to do what we've got to do at the end of the day. So I don't, if somebody's not having GI based issues, it's still reasonable to look at microbiome, especially if you're looking at these new checkpoint inhibitors out there. And we know that there is an initial characterization of people who are responders and not responders based on certain bacteria in their gut. Go figure, right? Well, kind of knew that was immunologically relevant. People have been taking probiotics for a long time. And I got to tell you this, for the parents out there, one thing I've recognized in 20 years of practice is there is a commonality in people over the age of 70 who seem to get diagnosed with cancer, but don't necessarily have as bad a disease as other people, and they seem to have been taking garlic and B vitamins over the long term. I don't know what brought that up or made me think of it, but when you start thinking about epigenetics and just like what may matter in the long run, it's something that I've noticed, because I'm always counseling parents to make sure that they're taking care of themselves, taking a multivitamin, taking an antioxidant. I know it's hard to get sleep because a lot of times they're on the internet, until they fall asleep on their keyboard, researching and looking and trying to do what they can. So it's important always to help treat the parents. They can't get an infection, or else then they're down and they can't take care of stuff. So you've been
yeah. No, like I was telling you, I'm well underway on my kind of crash course into an integrative approach to childhood cancer, kind of step-by-step course sort of thing. And there's a whole section in there on just being the best that you can be, and that does include taking care of yourself, because like you said, I mean, vividly remember waking up with my face in the keyboard, with my face in the book, and really having no clue what I'd read for the past hour before finally passing out. And it's just like, well, I just have to read that again now. So that's not really the most efficient use of my time, but it took me a while to learn that lesson, because it's almost like a pride thing. Like you want to feel like you're doing as much as you can, but at some point you're not doing as much as you can.
I bet. What else? Lab testing. I don't know how much you've had about lab testing on the show.
My dog is trying furiously to get into the room. 1 second.
That's okay.
He's less of a distraction inside than outside. Hey, there he is.
Trying to eat my macadamia nut butter.
Just a little bigger than my Chihuahua. Questionably a little bit of wiener dog in there, but I'm not sure. Lab testing. So we've had a bit of it on the show, but not extensive. And I guess that's the next, on the same lines of any microbiome tests you like, in terms of the liquid biopsy, trying to get as much information on the cancer as you can. With the caveat that it's different for every patient and all that, but I don't know. Do you just want to dive into like kind of
information about the cancer is huge, and I live in the world of circulating tumor cells. I have to say, for full disclosure, I'm a paid consultant to Biocept, which is a company in San Diego, which, to my knowledge, at this point has the world's best platform for detection of circulating tumor cells, especially those that have been epithelial to mesenchymally transformed and are considered stem cells. This is hugely important in the world, and there is so much data currently and consistently being generated on the importance of circulating tumor cells. The problem is it hasn't really hit home in the world of general medical oncology. So there's still a lot of skepticism. And my experience has been that in talking with our conventional colleagues or patients, circulating tumor cell detection really doesn't necessarily change how the conventional model is going to, doesn't really create shift. But in my world, in my treatment plans, if I see a change in circulating tumor cells, every one that I see is a new opportunity for metastatic disease. And for our patients who already have metastatic disease, and some docs may think that circulating tumor cells are not that big of a deal, to the patient it is. And it's not just creating hype about it, because you want those to go away, because then you're only left with the metastatic disease you have and not chances for other ones. So for me, I think the platform of circulating tumor cells, and I've been professing this for almost 2 years now, that is how you find disease. It's a window into the world that we knew was there, but we couldn't see before. And so if you can get a tumor cell, it gives you information about what's going on. It's different than a liquid biopsy. A liquid biopsy is looking at circulating tumor DNA for the most part. Obviously, there are certain markers that you can find on a tumor cell that's circulating, but you got to be able to detect the circulating tumor cell before you can find the marker. So here's an example from a non-pediatric perspective. Because right now, I believe all pediatric cancers would be considered research-based and experimental in terms of looking at circulating tumor cells, but in the world of adult oncology, let's say that somebody has estrogen receptor positive and they're not an estrogen and find circulating tumor cells and they are not estrogen receptor positive. That is impact. And let's say that somebody that creates a higher level of testosterone in their body, and these circulating tumor cells are not only estrogen receptor.
I think did you put something on the mic again?
I don't know, did I? Probably. I probably don't know where my mic is. Is that good?
You got a little quieter somehow.
Okay. So I was giving an example of a woman with breast cancer, let's say, that was estrogen receptor positive, went through conventional treatment, is now placed on a drug that blocks the formation of estrogen from testosterone, thereby sort of pushing the testosterone a little bit higher. Let's say a circulating tumor cell is found, or a group of them are found, that are estrogen receptor negative, but they're androgen receptor positive, which means that the androgen, which testosterone is a member of the androgen family, may actually push the growth of that lesion and may substantiate it if it becomes a metastatic deposit, whereas the anti-estrogen isn't really doing anything because it's not an estrogen, it's estrogen receptor negative at the time. So to me, you asked about how do you get information about the tumor. Well, it depends where you are. And what I mean is where you are in the process. If you're 2 years past diagnosis and a doctor wants to go get information from an old tumor sample because now somebody has metastatic disease and general treatments aren't working, they want information about the genomics to look for some kind of targeted therapy, is it really the best thing to look at a non-metastatic early disease? Is that going to be the true genomics of what has happened in a different soil in the body? So circulating tumor cells allow us to look at the most current accessible from without a biopsy perspective. So big fan of that. Also a big fan of the circulating tumor DNA when it matters. In terms of naturopathic medicine, I don't think there's as robust of treatment strategies when you're looking at circulating tumor DNA. I think that's more focused on pharmaceutical medicine. Not that I can't prescribe those medicines. I am, in the state of Arizona, we have very broad licensure for prescription. But circulating tumor cells really matter in my work. It shows me disease. It shows me certain personalities of disease. And not all circulating tumor cells are created equal too. There's different levels of characterization, which is one of the things I appreciate about the labs that I use to detect those.
Could you expand on the difference between a test for circulating tumor cells and the circulating tumor DNA, like a liquid biopsy, that sort of thing? I kind of had the two conflated in my mind, but it sounds like they're two different things.
Absolutely. So a circulating tumor cell test detects the presence of living cells in the blood that meet the criteria of a circulating tumor cell based on each lab's definition. Biocept, the lab that I said that I do consult with, and one of the reasons is because I'm trying to spread the word, because I think it's incredibly important, and I think it is absolutely one of the futures of diagnostics and how we're going to go about treating people. Right now, circulating tumor cells are not able to be used as initial diagnosis. You can't just look in the blood. There's no test right now that allows you to look in the blood and say, oh yeah, you have cancer, when you were previously undiagnosed with cancer. But if a circulating tumor cell, a living cell, is found in the blood, that's just it. You enumerate, you count the number of cells. You don't say what kind of cell it was, what the origin was. It's just that it's there and it meets the criteria. That's it. Period. The end. What's the issue there, though? The issue is that those are circulating, and for every cell you find in the body, and you sort of multiply that by the number of milliliters of blood in the body, you have that many chances for that cell to metastasize. But like the trail analogy that you and I were talking about, doesn't necessarily mean that it will, but it does have the propensity to, and that's important. And why is it important? Well, let's just say somebody has cancer, or a diagnosis of cancer, and their last scan showed no evidence of disease, and they're on monitoring. And 3 months later, they get another scan, no evidence of disease. 3 months later, no evidence of disease. Well, let's go to 6-month intervals. So now you're on 6-month intervals. Even if you were on 3-month intervals, it may take a while for a circulating tumor cell to make it become a metastatic deposit and get enough sort of traction to expand and to become visible on a scan. That could take 6 months. But in the meantime, if we're looking at circulating tumor cell changes, and if we see an increase in the blood, we can help predict what somebody may see on a scan, and we may be able to save them from metastatic disease. I can't say that we can, because the definitive studies aren't there. But if you look in the peer-reviewed published research, they're prognostic in many types of cancer, and they give you information about treatment response. But beyond that, in a no evidence of disease scan, helping to predict what you might see and keeping these people free is very important to me, because it matters to my treatments. It might not matter in the conventional world. It all matters on if you have something to test. I mean, if you're testing something, it makes sense that you're able to do something about it and treat it. And that's where circulating tumor DNA are products from the cancer cells. They are not actually cells themselves. And when they say liquid biopsy, one of the most famous ones is what's called EGFR, epidermal growth factor receptor. And there's subtypes of the EGFR. That is trying to determine if a small molecule, sort of like a tyrosine kinase inhibitor type oral therapy or even IV therapy, would be appropriate for a person to go on. But you can't go on an anti-EGFR therapy if you don't have an EGFR issue. But what's more is that if you have, now EGFR is a participant in a series of steps that create either cell survival or cell proliferation. So it depends. If you have a mutation at the level of EGFR, but you also have a mutation a step or two below the EGFR, blocking EGFR is not going to matter, because the cell is just going to revert to using the downstream issues. It's sort of like if you want to go to the store and you want to make a sandwich and you don't have any bread. Organic bread, right? So what, you got a big decision to go. You got to grab your car keys or your bike, get to the store, buy the bread, get home. It's a series of steps. Let's say I didn't want you to get bread because I didn't want you to make a sandwich for whatever reason. Then I could take your car keys. And that's like having an EGFR mutation. Well, you could call him, a ride share. You could walk. Somebody could drive you, you could ride your bike. That's like having a downstream effect. So blocking your car. So that's generally how I understand liquid biopsies to be utilized.
I gotcha. And while we're on this note, I think the most well-known test of this nature at all in the lay world, I guess you might say, when we're looking at all this stuff and getting fire hosed with information on the internet, would would be the grease test, which is, you know, the lab in Greece that they, you know, at least profess to. I've heard mixed opinions in the naturopathic oncology world on it, and I guess I'd be interested to get yours. But you know, that's they you know, the report you get back from them has a circulating tumor cell count. It has you know, different genetics that are either turned on or turned off, that sort of thing. And and people are getting that test kind of for themselves, direct or under the, you know, counsel of a cancer coach or a, you know, naturopathic doctor or something like that. What's your opinion on that one?
My opinion isn't for public knowledge. You can come see me as a patient.
Very good. Very good. And so I guess now that we're talking, well, yeah, we kind of got a broad overview of lab tests, and that, I mean, obviously getting these tests through you, Dr. Rubin, and having you interpret them and come up with a plan based off of your years and years of studying and experience and so on and so forth, clearly sounds like the way to go if you know, if you want to be doing the most for everything you can for the cancer diagnosis. That being said, like we were talking about you know, before we started recording, not everyone is going to be working with a naturopathic oncologist for one reason or another. Either they're in a state that does not license naturopathic medicine at all, or they just straight up don't have the money to be paying for consultations, but they do want to, you know, they do want to be doing everything they can from the integrative natural side. I guess two-part question. One, if someone does want to be working with a naturopathic oncologist, but they're in a state where it's not allowed, what is your advice for that person? And then the very close follow-up question would be, you know, for whatever reason, if they're just, you know, consulting with somebody in your line of work just isn't in the picture for one reason or another, just any high level philosophy on, you know, making the stuff work, you know, in conjunction with conventional medicine, doing your own research, that sort of stuff.
Yeah, sure. No, good questions. Part two first. If somebody doesn't have access to, can't afford, or for whatever other reason isn't able to consult with a naturopathic oncologist and they're sort of going at it alone, it's always a good idea, number one, to tell your healthcare team about it and to share with it, and even to make a specific appointment to bring in information about it. Like you said before, everybody, you know, all doctors are doctors to begin with. Whether you're an allopathic or a naturopathic or an osteopathic, that's an area of specialization. And then doing oncology is an area of subspecialization. But at the end of the day, we all know physiology. We all understand that. So if a patient if a parent comes in and, you know, has you know, can share some data or some research, because there's got to be a reason that somebody's going to take something and they make the decision to do it. And if you're just doing it blindly because somebody said it was good, it's probably not a good idea. But I would just say bring it in and share it, and, you know, have a discussion about that. But do it in the context of, and this is a very important point, don't bring it up at the end. And make sure that the team knows that that's something that you want to be done, because then they'll set aside time for it and they'll actually put some good mind to it. Or tell the cancer care team or the nurse coordinator or somebody who has, you know, time to go over that with you. That would be my thought. And then in terms of how people can work with a naturopathic oncologist when there is not one in the local area, I know myself and a lot of colleagues will do phone consulting based on telemedicine laws. And I'm always an advocate for making sure that the local main treatment team has access to whatever the naturopathic oncologist is prescribing for them, or whatever lab test should be sort of open source, if you will, and always encourage parents to either have, like myself or one of my colleagues, talk to the main treating physician, especially with children, you know, especially with children, because most of us treat adults. And the practice of naturopathic pediatric oncology and the practice of pediatric oncology and conventional medicine is not the same as treating adults. It's just not. The drugs may look the same, but it's not. The diagnoses are different. The regimens are different. The amount of chemotherapy given is different. The, you know, it's just a different, it's different. I gave a presentation about this at the ONC-ANP 2 or 3 years ago, to make sure that is going to delve into the world of pediatric checkup board. It's just different. It's different. So
very good, very good. Yeah, it's and just for your information, we have we got parents of kids going through cancer listening to the show. We have people themselves going through cancer. We have people that just want to prevent cancer. So it's certainly a mix of everybody dealing with cancer for one reason or another. But yeah, I'm glad you made that point, because it is pediatric
yeah,
oncology. It's different. Yeah, for sure. And so I guess either way you want to look at it, for people trying to do everything they can from an integrative perspective, be it maybe they're going alone, or just for the general purposes of getting as much information out there for how you do things as possible, specifically under the for the specific purpose of trying to mitigate as much damage as you can from, say, chemotherapy. Obviously, every chemotherapy is different, every patient's different, that sort of thing. But do you have any kind of just high level pointers, I guess would be the word, or just
yes.
philosophies on how you go about that?
Yes, my experience in the world of pediatric oncology has been that children are remarkably resilient. They're kids, they bounce off walls, they jump up and land on the ground like we used to do when we were kids. We just forgot, and we can't do it anymore because our bodies don't have that growth factor. Their cells are not young. The genes are different. We have biochemical and emotional baggage. But what I say to a lot of parents is we can get caught up in the details and the worry of what could be, but in reality, the kids can generally detox chemotherapy pretty well on their own. If the most important thing is the nutrients that are required for the body to heal and to be resilient, and that's food. Most of the food out there is crap, right? It's just bereft of true nutrition, or it was robotically grown, or the water is bereft of mineralization. It's just not what the human genome and human tissues developed with. And that's very important, is to realize that we have bodies that developed however you philosophically or faithfully believe that they developed, what they did, right? And without chemicals, because we invented every chemical basically that we're using. It's all human. So you've got to realize what it takes to get back to the earth. And so for me, especially post chemotherapy in a healing phase, eating the right food, making sure that the person is insensitive to certain foods to reduce, so that reduces inflammation, and getting nutrition in pretty hefty amounts pretty quickly and pretty soon after their conventional therapy is done, it's pretty key. And using the general nutrition, I'm not talking about specialized anti-cancer nutrients or medicaments or nutraceuticals. I'm talking about the basics. It's that and movement, hydration, nutrition still outshines everything in the world of adult and pediatric medicine when it comes to getting them through. Now, that doesn't mean that taking IV vitamin C doesn't help, because it does, because we see that. But not everybody can get IV vitamin C for one reason or another. Does that mean people should take huge doses of oral vitamin C because they can't get IV? No, it doesn't mean that. It means that there's maybe other things out there. But that's my main thing, is to focus. And even if you're using a nutritional supplement, just because you read about it and just because it may be at the health food store doesn't mean that it's appropriate, because there are certain chemotherapies that negatively interact with these nutrition. So that's what I'm saying. You got to tell your healthcare team.
Are there any resources available to the common man, either in book or online form, that that would be advantageous to get a hold of for looking into some of these possible negative interactions, that sort of thing?
Well, the peer-reviewed literature is obviously PubMed. The Oncology Association of Naturopathic Physicians has a project called KNOW, KNOW, which is, as you know, Knowledge in Naturopathic Oncology website. It's probably the most robust clearinghouse of legitimate, validated information that I know of on the planet regarding integrative work. That's and it's a continual work in process and continuing to build. There are responsible shows like the one I'm on right now, your show. You're doing it the right way. But there is a host of yes out there. People hawk product. People hawking product that may be dangerous to people. Fudging protocols to, I mean, I remember a patient came in, brought in by another ND. They joined for the council. This person had pancreatic cancer. And they're like, oh, we've been on this protocol. We got off the internet. We had a consult with the company, et cetera. And they gave it to some, like, this is a prostate cancer protocol. This is an obviously adult. I looked at it. I just knew it right off. So I'm like, all right. So we went online and we saw, sure enough, it's a prostate cancer protocol, but it'll work for this, you know. So you got to watch out, especially if you're a parent and you're sort of desperate. You don't know where to turn. You don't have resources. You're new to this whole thing. And you find somebody that seems to know something and is promising. They're going to sell you something. And you got to be really careful. And that's why I'm like, share this with the doc, because docs can weed through some of that stuff. But I would say, you know, like the NMTRC that you and I talked about, the neuroblastoma, medulloblastoma translational, they're interested in integrative medicine. I've helped with that organization, helped get some of the, natural products through the FDA for their studies. It's important because parents are, like you said, are out there trying to make sure that you make a difference for your child, and they'd be mortified if they made a mistake, I would assume.
Yeah, I would assume.
The internet's a dangerous place. I used to, a lot of my presentations in the early 2000s, I used to have a slide that said, internet plus credit card equals problem. And so,
overall, we could have been a little more refined in our approach. That's for sure. I probably spent, $500 just in overnight shipping charges.
Right.
The day we found out. Yeah.
Got it.
But so especially with pediatric oncology and adults to that point as well, more and more immunotherapy and checkpoint inhibitors and conventional medicine bleeding into, you could almost call it integrative medicine, just in the sense that they're doing something besides chemotherapy and radiation and surgery. I guess in general, do you have any thoughts on like that stuff from, how effective is it? How worthwhile is it? That sort of thing. And then secondarily, kind of the same question. How do you go about interacting with it from a naturopathic perspective?
You mean are you talking about my opinion on the efficacy of some of the newer treatments coming out? Okay. Here's the deal. It is a good time for conventional oncology. Things are changing. It used to be, you'd have I'm in practice 21 years, so I feel somewhat legitimate in being able to look back over 2 decades of work. And there's not that many new drugs on the market that are traditional cytotoxic chemotherapeutics. What there is new algorithms and sort of, shuffling the shells around, where's the piece of paper under the shell? What regimen do you use? There was a lot of that, adding another chemo, subtracting it, doing studies. And all along the way has been biological therapies. Newer ones, tyrosine kinase inhibitors, small molecules, MET inhibitors, MEK inhibitors, EGFR inhibitors, all these ones. And then knowing full well, I know conventional oncology knows that the immune system is just where it's at. The problem is getting immunotherapy into the current medical model without it being individually, hugely burdensomely expensive. Because not only do you have to develop the drug, but you have to get it through clinical trials, get it accepted so that you can utilize it. That's where there's a huge amount of money, and that's what drives up the cost. So I think this is a great time right now, and probably, if I'm looking into the future, a good time, going to continue to be a good time for conventional oncology, because there's paradigm shift. We've been waiting for this. And science is catching up to what a lot of people have wanted. There's a lot of people who are surviving with disease who have been waiting for these drugs. I have them in my clinic, and they're doing better because of it. But they wouldn't be here without the integrative work that we do. And I can't give you a data set to tell you, because the data is being generated right now. Like, there's a study ongoing called CUSIOS, Canadian United States Integrative Oncology Study. Dugald Seeley is the chair of that and the PI. I mean, it's multinational, but I know it because I'm a doctor and I'm in the trenches every day with my patients. And I can say that because I'm in practice, and I know because I can compare them to other patients. And I know that that's, what we're helping to do. And I think my conventional oncology colleagues would agree with me if they could say something like that. And that's why I think it's such a good time right now for integrative medicine, is because we can do those things together. Conventional oncology does things that I simply just can't do, and vice versa.
Yeah.
That's integrative medicine. So, and I forgot the second question because I was too into the first one.
I guess I mean, you already kind of touched on it, but just, your approach from, whatever you want to call it, complementing it, or, doing your side of things in light of the fact that, the patient is getting immunotherapy or just all these different things that are coming out, that maybe, there's not as much research on, a natural substance, how it is or isn't going to interact with, say, a chemotherapy, because that chemotherapy has been around for a while. People have been doing, tests and stuff like that, or running these experiments, or there's been a lot more, there's more data available on how something's going to react with the chemotherapy than there is on some of the newer drugs. So just any thoughts on, like, how you go about, prescribing natural medicines in light of the fact that, somebody's on something newer that there's not as much, experience with.
Number one, testing. But number two, the important point that you've made is that supplements, herbs, nutraceuticals always get the bad rap, but sort of in the dust are all the other meds that people are on, anti-cholesterols, all the antihypertensive, the mental emotional, when people medicate their psyche with antidepressives or anti-hallucinogen or whatever they may be, or antipsychotics, what about those? People don't pay attention to those. What do we know? Are they going to act at the level of metabolism, right? Like CYP3A4 or 2D9, those types of things. That's about it. But when you throw those into the wild of the body and you don't know what kind of epigenetic changes are, I don't know why people pick on herbs. They forget about it. And so it aggravates me a lot in clinical practice because it's simply not fair to the patient. And that we're cavalier as a medical system in general to think that we know what those drugs do. All you have to do is look at the commercials on TV. Are you a candidate for this or this glucose lowering drug? Well, just make sure you don't have a history of these things. And, death is certainly one of the things that this could cause. I mean, I don't know the last time that echinacea caused problems like that. And so, plus a lot of the times the dosages aren't big enough for people to have negative interactions. So at the end of the day, if we have a study, we're going to pay attention to it, because data is data. But if you don't, and how I practice, we have structure function. We know what these things do. So if you have a chemotherapy that's an intercalating agent or an anti-tumor antibiotic, and you have an herb that you're trying to lower interleukin-8 with that's not anywhere remotely close to the mechanism of the chemotherapy, I think you as a physician need to be astute enough to know not only what you're giving, but what the other doctors are giving too. And therein lies the main challenge, and what makes our practice of naturopathic oncology more difficult is having to sort of know both sides of things and discuss those with patients. But in no way do I excuse side drugs for treating comorbidities from being in the mix of, we don't have studies on, the 9 other drugs that somebody's taking, if they interact together or if they interact with the chemotherapy, or how do we know that they're not stimulating tumor cells or not stimulating? And so that's my answer, and it will remain my answer. It has been for many years. And anyhow.
That's a very good answer. I like that one. We're getting about time. So I have my kind of 2 questions that I ask everyone at the end of the show, and I'll ask you those in a minute. But before I do, just, I don't know, do you, in general, and anything you were hoping to address to get out to the world for folks going through cancer from a kind of a tactical standpoint that we haven't covered yet. I guess I just want to make sure there's nothing else pressing on your mind or your soul.
No, I think we've said it. You've given me the opportunity to say it. I think what everybody kind of thinks is cancer sucks.
Cancer sucks. Yep. Yeah. Pretty
much.
But, in going through it, there's certainly, oddly a lot of beauty along the journey as well. So
Well said.
that's what we've certainly focused on over the last few years. All right, Dr. Rubin, that being said, 2 questions for
All
you.
right. What are they? I'm
First
anxious to
is,
hear.
if you had to boil everything you knew down into 3 golden rules, and those golden rules would be on how to either stay healthy and disease-free or become healthy and disease-free, whichever you needed to do, what might those rules be?
Well, the main rule is doing what humans are supposed to do that we've lost sight of because we're in the world of overnight shipping, so to speak, and immediate gratification. And it's the fact that, we used to pick our food from trees and from the ground, and we had a lot of bacteria that we ate, which is how we developed, and how we developed genomically, microbiomically, epigenetically, etc., is we're still those creatures, but we've created a world that impacts that in certain ways that causes disease. And if I were to boil that down, it would be the one term is called inflammation, which I think I'm going to guess that many of the practitioners or people you've interviewed have mentioned the word inflammation.
A couple times.
And that I'm talking about pediatric oncology, we are living in a world where our kids are seeing a 3D world via a 2D representation, which is a screen. And it's digitized. It's representing what you and I grew up with, being able to see true depth because we didn't have a screen. We looked out a window and we saw real things, which are now represented in zeros and ones. And this is going to be a problem, but it's not going to go away. And humanity is going to continue to develop in a certain ways. And so, but for the immediate, for now until 100 years from now, when we realize that genomically and we've sort of gotten over some of these humps, people still need to remember to drink water, sleep, stay away from their devices all the time, and laugh, and make sure you have good interpersonal relationships, and that you should do what a human body is designed to do, which is move, which is rest, and which is bring nutrition into themselves. And those are simple rules. And then you have to also be wary of what's out there, especially when you're either desperate or you're worried or you're really reaching because it's your child, and you got to stop and think for a second. And we know that probably in almost every situation, if you just stop and think even for a second, what happens next is usually better than if you didn't.
Most times, I'd have to agree with that. Those are
yeah.
Yeah, and good. I think you boiled it down to 3 there, but yeah, it was everything you just said was very good. That's for
Thank
sure.
you.
And then lastly, just if you had any kind of final thought or sentiment for those folks listening, going through cancer right now, either for themselves or a loved one, their child, that sort of thing, to kind of take us out, that'd be a good way to take it out.
Yeah. I mean, I think at the end of the day, being a parent myself, is the realization is we just don't have all the answers, and that doesn't mean that you have done something wrong.
Yeah. No, it's what I try to tell folks every day, because it's something I still battle with myself every day, is beating myself up for not having cancer solved. It's I'm certainly not the only one. That's for sure. Dr. Rubin, do you just want to let everyone know, 1, about your clinic, and 2, I know you're big into on-camp yourself, and I know we the term has been mentioned a couple times, but I don't think we've actually even defined what that is. So yeah, if you just want to let everyone know about those 2 things to find out more how they can get involved in those 2 things, that'd be a good way to take it out.
Well, thank you for allowing me to do so. So ONC-ANP, which is the Oncology Association of Naturopathic Physicians, was founded in 2004, with first and foremost looking to help protect the public. with the idea to create a board certification strategy and a clearinghouse for information and a place for the development and the invention of the naturopathic oncologist, which then came 2 years later in 2006, after the sister organization, the American Board of Naturopathic Oncology, was formed, test was created, criteria was created, and by 2006, the first 6 naturopathic oncologists in the history of ever were deemed fellows to the American Board of Naturopathic Oncology. So if your ND also has the designation FABNO, that is fellow to the American Board of Naturopathic Oncology. And that is the highest designation recognized by the American Association of Naturopathic Physicians to have expertise in the world of naturopathic oncology. And that website is ONCANP, as in Peter.org. And I certainly belong to that organization, am a board certified naturopathic oncologist myself. Our clinic is called Naturopathic Specialists, and it is in Scottsdale, Arizona. It is a multi sort of disciplinary naturopathic doctor clinic. We have 8 naturopathic physicians. A good, half or 65, 70% of the clinic is naturopathic oncology. We have 3 naturopathic oncologists and 1 naturopathic oncology resident. And we have 4 other physicians. It was co-founded by myself and my wife, Dr. Debbie Smolinski, who's a naturopathic physician whom I graduated with, and currently the vice president of the Arizona Naturopathic Medical Association board, and also the chairman of the board of trustees of our alma mater, Southwest College of Naturopathic Medicine. So very busy. She practices women's medicine at the clinic. I, of course, practice naturopathic oncology. We have Dr. Melissa Coates, another board-certified naturopathic oncologist, Dr. Lisa Elschuler, who is one of Debbie and I's teachers, actually, who's part of the clinic and a naturopathic oncologist. And then we have Dr. Amy Waite, who does environmental medicine, men's health, pain management. We have Dr. Walter Crinian, who's probably the most famous environmental medicine doctor in the naturopathic world, and also in integrative medicine. He sees patients through our clinic. We have Dr. Jessica Stefanski, who does women's medicine at the clinic. And we have Dr. Adam Kozin, who's our naturopathic oncology resident. And we also have another location in Flagstaff, Arizona. It's called Aspen Integrative Medical Center. Our partner there is Dr. Amber Belt. Graduated Southwest College naturopathic medicine about 12 years ago, which is my alma mater as well. And our website is listenandcare.com, all written out. And thank you for the opportunity to talk about this and to talk about philosophy of treating people with cancer. And one thing I'd like to say is I'm on a mission to help change the gestalt of oncology. And in our clinic, the term is people with cancer, not cancer patient. We don't use that. We believe that it's more important to have the person above the disease. And so we always say people with cancer or person with cancer. And thank you again, Ryan. Thank you for what you're doing for the world.
Yeah, well, right back at you. And yeah, no, I think I've always instinctively said something like we're going through cancer or, getting over cancer or something like that. But good
it's
stuff.
That philosophy.
Yeah.
Important.
Yeah. All right, Dr. Rubin, really appreciate the time.
Appreciate it.
There you go. I really hope you found this interview with Dr. Rubin valuable. It was a bit of a geek out at times. That was one of the more technical discussions we've had on the show, come to think of it. And if some of it was a bit over your head, I hope it gave you some good terms to look into further in your research. And I also hope it underlined the importance of working with someone who knows what they're doing with all of this stuff. I certainly felt like I needed to have it figured out all overnight, but it just doesn't work like that. There are people out there that have been studying the best ways to reverse cancer naturally, integratively, holistically, etc. for years. And for something like cancer, you just don't have the time to learn all that they know. So go to oncanp.org, that's ONCANP.org, and see if you've got a naturopathic oncologist in your area, or look Dr. Rubin up. As like we discussed in the interview, there are a few of these kinds of doctors that do remote consultations, and his clinic is one of them. And don't forget to register for the Toxic Home Transformation to make sure your home is not causing you harm and is in fact supercharging your health. You can find out how to make sure you've got both sides of that coin covered starting June 25th. And again, you simply sign up to watch for free at thetoxichometransformation.com. Music was provided by TheFatRat and Tasty Network, and all production was done by my wife and best friend, Teddy Sternagel. I am Ryan Sternagel. You can find us at thesternmethod.com. And if you are going through cancer, just keep going. God bless and Godspeed.